Ladies and gentlemen, welcome back. If you are still following us, please just relax. You can take a glass of water and make yourself very comfortable as we are going to be introducing you the third session of this forum, which will be based on challenges in optimizing surgical care in Africa, the way forward. That session will be moderated by Madame Irene Nzirasa. She's a public health expert with background in nutrition and sexual and reproductive health. She has a master's degree in international public health from the Liverpool School of Tropical Medicine. She worked with the Ghana Health Service for 8 years, where she served as a senior nutrition officer, community-based health planning and services coordinator, and a quality improvement coach. She currently works as a health policy and advocate associate at Operations Smiles, where she supports ministries of health, partners, countries, and other stakeholders to increase the prioritization of surgical care through NSOAP development, implementation, and evaluation of grassroots advocacy. Doctor, the floor is over to you. Thank you.
Thank you very much, Vanessa, and good morning, everyone. I'm having a few network challenges, but I hope that you can hear me and I hope you can see me as well. As Vanessa mentioned earlier, this is the third session of the Nkafu African Health Forum, and we are going to discuss the challenges in optimizing surgical care in Africa, the way forward. My name is Irene Jirasa. I'm a Ghanaian and I'm based in Ghana. So for this afternoon session, we are going to have our panelists join us, and I'm going to introduce the panelists we have for this session. Our first panelist is Dr. Mbokake Martin. Dr. Martin Mbokake in Cameroon is a consultant general surgeon with vast experience in tropical surgery. He is the director of the Buea Regional Hospital and senior lecturer in the Department of Surgery and Specialties, Faculty of Health Sciences, University of Buea. He is also a country representative of the Mashal Israeli Foreign Ministry Program on Emergency and First Aid Training in Africa. He is a member of the National Trainers on Advanced Trauma Life Support and Advanced Cardiac Life Support, a medical regulation and first aid. He is a member of the Regional Blood Transfusion and Medical Evacuation Committee, a rapporteur of the Regional Scientific Committee for the Southwest. He is a researcher with about 25 publications in and out of surgery. He is also a community developer and an entrepreneur. I'll quickly introduce Dr. Stanley Aruyaru as well, who is going to be part of our panelists for the session this afternoon. Dr. Stanley Aruyaru has 11 plus years experience in the Kenyan healthcare space. Dr. Aruyaru is an internationally recognized surgeon, a public speaker, and an award-winning healthcare leader. He is an influencer on surgery and health in Kenya and across the region. Dr. Aruyaru is passionate about advocacy for effective and responsive quality healthcare delivery systems. His advocacy stories can be found across articles, podcasts, radio, and TV talks, besides his social media handles. His YouTube channel, Something About Surgery, discusses surgical topics of interest to the lay people. His first book, The Chronicles of a Village Surgeon, documents the memories of a dedicated surgeon in rural Kenya. In 2021, Dr. Aruyaru was among the winners of Business Daily's Top 40 Under 40 Men in Kenya, an award that recognizes young people making significant impact in various spheres of life in Kenya. Dr. Aruyaru serves as the Director of Medical Services at the St. Teresa Mission Hospital and the Chair of the Scientific Committee of the Surgical Society of Kenya. He is a member of the numerous international professional bodies and a global surgery doctoral scholar. Besides health, Dr. Riaru is an award-winning public speaker, a youth mentor, an advocate for charity work in education and health. He also serves in boards of various public and non-profit organizations and institutions. Dr. Stanley Ariaru, you are welcome to the Nkafu Health Forum. So I'll go on to introduce Dr. Jonathan Aja, who is also a surgeon, a lecturer, and a module lead in clinical skills at the University of Central Lancashire in the UK. Dr. Aja is a medical graduate from Ahmadu Bello University, Zaria, Nigeria. His expertise covers global health and global surgery, humanitarian medicine, clinical research, and medical education. He is a trained surgeon with primary fellowship and membership in surgery at the West African College of Surgeons. And also, he has a membership of the Royal College of Surgeons of England. He's an elected member of the American College of Surgeons, International Society of Orthopedics and Traumology in Europe. He holds a master's in public health from the University of Manchester, England, and an MSc in surgical sciences from the University of Edinburgh in Scotland. Humanitarian medicine certification from Medicine Sans Frontiers, and eligibility for the Diploma in Tropical Medicine and Hygiene of the Royal College of Physicians of London. Dr. Aja has won 2 Commonwealth scholarships, totaling over £41,000 in the last 6 years. He has over 4 years contribution to science as a peer reviewer for Springer, USA. He publishes in peer-reviewed journals and presents regularly in conferences around the world and in the UK as well. He's a lead innovator, people, physician-led open access, primary long-lasting healthcare everywhere in Nigeria and West Africa for $2 per month per adult or 3 to 5% family income concept, presented on the 4th of May 2022 at the Forum of International Challenges University in Birmingham, UK. Doctor, you are welcome on board.
Thank you very much for having me.
It's a privilege to have you all. We are still waiting for Dr. Stanley Ariaru to join. We had one more panelist, Prof. Nia Zalemia, who is unable to join us this morning due to a few issues. And so we'll get going. We'll start the day. So able experts in global surgery. I mean, it is very clear as at now that the case for global surgery has been made. We all know that we have about 5 billion people lacking access to surgical care across the world. And in Africa, where we have the greatest burden of conditions amenable to surgery, this is where we rather have fewer experts in the field of surgery. So Dr. Stanley, let me start with you. Give us a general overview of what the surgical situation in Africa looks like.
Thank you, Irene. Good afternoon from Meru, Kenya. It's a pleasure to be here with my fellow panelists and the attendees. Perhaps just in retrospect to remind the team of an event in 1978 that brought people together in a city in modern-day Kazakhstan to chart a way forward in matters global health then. And at the end of that meeting, all these delegates would come up with resolutions that were dubbed the Alma Ata Declaration. I know every public speaker, every public health expert, any healthcare leader knows about the Alma Ata Declaration because it was a giant leap for public health in the world. But it missed surgery. And for reasons we do not know, but which have been argued differently, surgery remained confined to the periphery of the global public health agenda. So much so that colleagues would nickname surgery the neglected stepchild of global public health. And that has changed then since the 15th resolution of the 68th World Health Assembly that recognized the importance of essential surgery and anesthesia care as components of primary health care, especially in the thinking of universal health coverage. Now, having put that into perspective, then we come and ask ourselves, where are we? And I think that is an important question to ask because we have got two dichotomies. What is happening is we have a dire situation on our hand in terms of what we need to offer our population in terms of surgical service vis-a-vis how we deliver that. As it stands now, if we pick one thing that we can use, and that is the Lancet Commission on Global Surgery, and look at the metrics that are available, we will find that we are faring poorly. If I use Kenya, which is a lower middle income country in sub-Saharan Africa, as an example of sub-Saharan Africa, we have 2.35 surgery and anesthesia care providers per 100,000 population. That is against the Lancet Commission request or requirement or proposal of 20 per 100,000 population. And the other 6 indicators of the Lancet Commission on Global Surgery are not doing any better. So what I can say is, at the moment, the place of surgery in the African continent is in need of more. And once we agree we are in need of more, we can now start breaking down what are we in need of. Are we in need of infrastructure? Are we in need of human resource? Are we in need of responsive systems? Are we in need of better financing? And all of those can be picked. But one thing I can say is we are not yet there. When I trained to be a surgeon, I wanted to be a surgeon who fights diseases, those dangerous diseases that consume human lives, the hernias, the infections, the cancers, you name them. But no sooner had I become a surgeon and was posted in rural Kenya than I realized that I needed a little more just than the scalpel to fight diseases, because however much I volunteered myself to be present within the golden hour of trauma patient, within the platinum 15 minutes of trauma patients, if there was no network to transport the patient to come to the attention of the surgeon, then I wouldn't be able to impact at all. So working alone as a surgeon to just influence within the OR perimeter is not adequate, because it is akin to trying to wipe dry or mop dry a floor without fixing the leaking tap. And that is the situation at the moment. I think the situation at the moment is to start fixing the leaking taps and forget mopping the floor. That applies for surgery, that applies for most other health interventions. Thank you, and back to you, Irene.
Thanks very much, Dr. Aria. You made a very important point there, talking about looking at surgical care as an entire systemic issue, and the fact that you mentioned that we should begin to see surgical care as a component of primary health care, which we forgot, because all this while when we're talking about primary health care and rural health, no one actually focused on surgery. No one thought deep to realize that people in the rural areas would also require surgical care. We actually left them behind and focused mainly on, I would say, the disease prevention and disease control and nutrition aspects. I'll go to Dr. Jonathan Ajana. What's your take on the surgical situation in Africa?
Thank you. Can you hear me?
Yes, we can.
Yes, I'd looked at it for a while, and I wrote a paper in 2018 looking at where the problem of, because the people, what Dr. Stanley, has said is our people don't get the surgeries they need when they need them. And the WHO, they talk about bellwether procedures. So things like cesarean section, things like fixing a fracture, things like a laparotomy. And now what I did look at, beyond the systemic issues, I looked at how long we've had surgical colleges. If you look at the West African College of Surgeons, the sub-Saharan West African, we've had them for about 60 years. But if you look at the output, the number of people that go on to become surgeons is low. So I'm going to share my paper in the chat box, and I published it in Séquence, which is an orthopedics journal. But what became clear was, even though we needed more surgeons than the UK was graduating much more surgeons, because a surgeon needs to be trained. We had a very high attrition rate in terms of people trying to complete surgical training. As far as I can tell, in Nigeria, not a lot of people, the interest to become a surgeon is beginning to dwindle. And the reason for that is Now, I'm not saying the colleges have not done their best. I'm just saying that the production of surgeons is way more slower than the continent needs. In terms of the work that a surgeon needs, the surgeon would need a couple of more things. And that's why I think WHO has avoided surgery in terms of an intervention. And the argument is it's more resource intense. I think, yes, surgery is generally more resource intense compared to other things. Our health systems need to be better designed in a way that it allows surgeries to be carried out easily, and that would increase the volume. So those are two of the areas. I've shared the link to the paper where I looked at the production of surgeons, but I think the funding for the surgical care for our people in Africa needs to be improved. There are various models for that, but I think it would probably derail this conversation a little bit. So I'll probably pass the conversation back to the moderator, and thank you for asking me that question.
Thanks, Dr. Aja, for actually comparing it a bit to the situation in the UK. So clearly you could see that comparing high income and low resource settings like Africa, surgical care seem not to be developing at the rate that we would have desired for it to progress to. Dr. Ariaru, what do you think is the greatest hindrance to the development of the surgical system or surgical care in Africa?
Thank you, Irene. And I really want to recognize first what Jonathan has mentioned about some of the misinformation that was passed forward as the reason why surgery did not require to be funded. One of them is saying it's resource intense. That is sometimes accurate, sometimes not accurate, especially when you mention the bellwether procedure that is mentioning. And if to quote Professor Miara, who says, we don't need a moonshot. All we need in surgery are resources that arrive on time and structures to make sure that a girl is saved from a perforated appendix, a lady is saved from a postpartum hemorrhage, and a gentleman is saved from a broken femur. Essentially, the bellwether procedure that we look at in surgery is laparotomy, emergency laparotomy, open fracture surgery, and cesarean delivery. If those are offered, then we will have taken a huge chunk. And when you look at those and compare them, data after data after data has shown that trauma alone, which is just a subset of the morbidity in surgery, takes on more lives than HIV, AIDS, TB, and malaria combined, which have always been the heavily funded when you look at the donor funding. Now, I want to come to your question, and the question is looking at what is the hindrance to the development of surgical care in Africa. And I want to pick from where Jonathan has left. It is the training. If you want to start at the training, at the policy level, if the population is growing at that rate, and you have projections to tell you how many surgeons you need per unit of population, then if you don't train, it is not a miracle. It is not rocket science. When that time comes, you won't have the resources. Countries that have gone ahead, projected this, and did very well in terms of not just training, the second bit, which is incentivizing the surgeons to remain within their home countries. And I know, again, myself, Jonathan, and the like, will look at a lot of data that's looking at the brain drain in terms of surgical workforce. So as the West was training, they were also attracting. So people may be trained in the low and middle income countries, but if they are not retained in their countries first, or in their communities, because you can still have intra-country brain drain, which is the rural to urban brain drain, then that will continue to skew the population access to services. So that has to be taken into account. When we train the surgeons, we must remunerate them competitively, and then we must enable them to work by offering them the resources and the infrastructure they require. So that goes in terms of looking at the training, the policy, the remuneration of the human resources. And that is dependent heavily on the policymakers, but vitally important on the political goodwill. All of us will know from the various areas we come from what a political goodwill can do. If there's a political goodwill from the presidency downwards, people can wake up, fund surgery, construct multi-story hospitals, and equip those facilities. We have that evidence left, right, and center for different strategies. So that needs to be taken into consideration, because if that is not there, then the rest is just too much talk, hot air, like we say in Kenya, without frame. If I listened to the last discussion that was talking about the Abuja Declaration, if you just look at the Abuja Declaration, where there was commitment ab initio to render some amount to health and ring-fence it to health, and then audit it, then you realize a lot of departure from what political leaders undertook to deliver. So that is an example of what I'm talking about when I talk about political goodwill. The same can be said about the Millennium Development Goals that gave life to the SDGs that we talk about today. But outside of the political goodwill and the policy formulation is something else that every so often when we retrieve into our cocoons as doctors, as surgeons, we start to confront is also the work ethic of the surgical service providers who are in the public sector. Because what happens is you end up with the low morale of the service providers or the healthcare providers because of remuneration that does not arrive on time or that is not competitive. And then even when it is there and the resources are there, then you don't find the work ethic for the same person who, if you found them in a private sector, they would be head over heels delivering round the clock on the patient. So you have really highly trained people, you've ticked the box, you've recruited them, but how is the work ethic in terms of delivery? And that is an issue that comes up every so often in the Kenyan space, because everyone will say Kenyan doctors are not working. A whole three weeks back, we had a whole editorial, a whole front paper, 2 days in a row, talking about absentee doctors. So there's a lot of confusion, because the moment you don't staff people enough and you have a surgeon who is available to cover one hospital round the clock, then you don't expect them to be there every time, because if they work at night, during the day they will come and do their work and probably retrieve to rest. But if you staff them adequately, then you would avoid the leeway of telling them, okay, you can leave the station a little early. I know you are tired and I know you want to go somewhere and come back at night. So if we have adequate staffing, then we can start tightening on the human resource management aspect. So the work ethic needs to be looked at in the public sector from my experience, and I am hoping to hear from the panelists' experience, because that is a sore thumb. You keep asking for these millions to train the surgeon, but when they hit the ground running, we are flooded with avalanche of complaints about our. The other bit directly connected is infrastructure. We know we can package so that infrastructure comes human resource. It is easier for surgeons, all the MRIs are there, all the critical care units are there. There's a hospital that can give them everything they need, as opposed to telling them, go there, we are going to support infrastructure and support equipping. So that also needs to be there. But finally, why as surgery remains on the periphery of this discussion, I think is because more surgeons need to take up their advocacy role. More surgeons need to wake up and say, wait, yes, I can operate, I can fix the broken bone, I can do all these other operations, but this and this and this must work. And the more we raise our voice, then the more we will be listened to. The more we sit on the table of decision-making, the more we will shape the surgical care in the African continent. Back to you, Irene.
Thanks very much, Dr. Ria. This conversation is getting very interesting, especially you bringing into the conversation our work ethics, talking about brain drain and all that. To our audience, I encourage you to note down your questions, because getting to the end, we will have some time for you to ask the panelists all your questions. So talking about the human resource for surgical care, it's a bit confusing, because we also know that we have training institutions in Africa. We have the West African College of Surgeons. We have the CUSECA training surgeons in our space. So Dr. Aja, what do you think the real situation of human resource in Africa is in terms of delivering surgical care? Do you think it's a challenge? Do you think it is part of the hindrances to the development in the global surgery space?
I mean, I think in terms of the capacity, it's very good. If you compare it with even if it's the developed countries, we've got, I think, 4 colleges if you put them together. You've got the WACS, you've got COSEXA, you got the national body in Nigeria, and I think in countries like Kenya, you've got MED programs, and South Africa. So I don't think the capacity to train surgeons in sub-Saharan Africa is a problem at all. What I think is, and then I think there's a good number of people that get trained, but they don't get retained, like Dr. Stanley has mentioned. Yes, the work ethic can be fixed easily. I think the reason why the government in most parts of Africa are not wanting to fix it is because they've not done all of the things in the contract of people. So they don't want to enforce certain things, and it creates sort of like disputes. So in terms of why surgical care is problematic on the patient side, at least in Nigeria, if you need to do an elective surgery, so think of any elective surgery from the brain to the foot, the patients need to look for money, they need to sell some cows, they need to talk to their family members to donate. And so they go through all of these things that eventually push them into poverty. And oftentimes when you're a surgeon, you also have to wait for them to raise money for elective procedures. So that current model is problematic. Now, until we probably adopt something that solves that issue of the cost of care, then certainly even the facilities to offer the care would be problematic. With modern surgery, for instance, from brain to toe, you probably need a CT scan. People don't like to just like open and explore these days because the outcomes is helpful because there's imaging. And from the patient's point of view, it tends to be overwhelming. I keep sending money to my relatives. I need to get surgery done. I need to do X, because I know, because we need to sit down, we plan with the patient. Okay, I need to go to the farmer's market. Now, if we find a model of health insurance that is sustainable, now funding is not bad, but funding oftentimes tends to treat symptoms. And so this problem of people, let's fly in surgeons, let's do free hip surgery, all of the fancy things. And then nobody does that again for 7 years. And I think the president of COSEXA, what's the professor? There's the professor and then the other guy. When I went to Canada one time, they really didn't like that model at all. And they said, how about the money you spend, if you give it to COSEXA, we can train more surgeons and they would remain. So model for funding needs to be sorted in some way, whether we opt to use that like it's here in the UK where it goes through general taxation, which comes with its own problem because the poorer the economy suffers, the more problem. But the UK is set up in there's tax, there's national insurance and things like that. The NHS is not perfect, but generally the problem on the end user in terms of getting access to care is not as problematic. America is, again, a different ballgame where they have people needing to pay their insurance, but entirely in Nigeria is missing. So oftentimes people want to come for their elective surgeries, people want to come for semi-urgent surgeries, but there's the financial access. And it's an area that, as far as I can tell, in Nigeria, the government do not want to discuss, but that needs to be resolved. And that's why the volume of surgeries, especially elective, that we can do. I'll give you an instance. We do a few laparoscopic surgeries in Nigeria. In the UK, took some time off from the university and spent like 3 weeks with the urologist team. We did, I think, 7 laparoscopic renal nephrectomies, and we had more patients to do. It's just that some of them for anesthetic risk reasons. And if you look at the UK is 70 million. In fact, I live in England. England is 50 million. And in Nigeria, I think in 6 years, we did 1 nephrectomy. I have no doubt in my mind that we have more patients needing that procedure in Nigeria, probably a large number of surgeons willing to do it, but it would cost about ₦1 million, even in government hospital to get that done. Even the doctors themselves will find it difficult to like bring out that money. So if we don't find ways to solve that cost of surgical care, and then I think the problems will continue to, and that's something that has to be done at state or federal level, preferably federal level. The model is created and the state governments can adopt it.
Thanks very much, Dr. Jonathan Aja. I think the issue of cost, I mean, is what prevents a lot of people from seeking surgical care in this part of our world. But also, could there be a situation that there is a proportion of the population who also have the money and could have afforded surgical care, but then due to poor infrastructure, they do not want to access surgical care in a part of the world because of the risk? I mean, Dr. Stanley Aruya, what do you think some of the risks of poor infrastructure in terms of surgical care can pose on an individual seeking surgical care in Africa? And how does that undermine the innovations and research that has gone into improving surgical care?
Thank you, Irene. I totally agree with Jonathan's input about the cost that has to be looked at. And even when you look at the public health sector, in terms of the primary healthcare, there's a lot of funding. And when we're having these conversations in the global surgery circles, we are saying we don't want surgery to go the model of public health, which depended heavily on donor funding, because then you get to a point where a critical mass of the population is held hostage by the donor funding companies when they withdraw. And we've had those experiences with HIV programs and various other programs. But let me come to your question, and you raised the issue of what are some of the unsafe practices, what risk do patients stand if we don't have adequate infrastructure, human resources? Absolutely, yeah. Absolutely. And we just, I think I will share that paper. I was part of a global search paper that looked at the correlation between hospital infrastructure and the mortality after cancer surgery. And their conclusion was damning. They said, irrespective of stage of cancer, irrespective of the specialist training, facilities or countries that had poor infrastructure, when you're looking at the level of the health facility, and a worse outcome. And that was an association to tell us that when a facility has heavy infrastructure, they are also likely to have specialists on board. If there's an ICU and there's an MRI and there's a CT scan, and then they are likely to get an anesthesia provider who is competent and a surgeon who is competent and an intensivist who is competent. These are the people who can pick the postoperative complications and address them. So that is me to say that if we have poor infrastructure, then the outcome of our surgical patients is going to be poor. Not because necessarily the specialists do not know what to do, but because they don't have the tools. They know if I was in an hospital X where I trained, I would have sorted this patient. But here I am. Now, the much I can do is to refer them. And then you want to refer them, there's no fuel for ambulance. Ambulance is not available. They don't have money to go. I have had patients who outrightly signed the dotted line and say, I am not going anywhere, let me die in this bed in your hospital. And what do? Do I chase them away? So those perspectives come. And if COVID taught us anything as a continent, it is if we have homegrown solutions, then we stand to benefit more. When the airspaces were closed, there was no travel, we just had to look internally and sort ourselves out. And that is the much we can carry from the pandemic. As Winston Churchill said, you should never let a crisis go to waste. That crisis of the COVID pandemic should tell us that we can actually be self-sufficient, that we can actually have homegrown solutions. So the outcome of the patient will be worse if you don't have infrastructure to support a good outcome. That is evidence-based. The second is that you will deny quality care. When you look at the Institute of Medicine, they talk about 6 domains of quality. What does it mean when we say a patient is receiving quality? One of those 6 domains of quality healthcare is timeliness. And that calls upon us to minimize harmful delays that would lead to complications. We talk about the golden hour in trauma. We talk about the platinum quarter hour in trauma. We talk about the golden window in patients who are having stroke or myocardial infarction. You can imagine if we don't have the infrastructure to handle that, someone who could be saved would die. Someone who could save would die. So what happens is you don't have infrastructure, you end up with harmful delays, you end up with mortalities or complications that could be averted, and it spirals into the social fabric, it spirals into the economic fabric of not just the family, but the entire society as a whole. So the second bit is those delays and long waiting times, be they for elective surgery that turns now emergency, or for emergencies that cannot be offered to salvage a patient's life, then means the population's health is not optimum. The other final one, which is very popular, is improvisation. If you don't have infrastructure, and I talk about the building or the equipment, you end up improvising. And those of us who have traversed the low and middle income countries will know how much improvisation we have seen. We can't even talk about them for fear of looking, appearing to be practicing witchcraft. So you improvise because you are always taught to do something. You always taught to do something, save this patient's life. What do you have? You have nothing. You have one rod for an open fracture. That means an L shape or an A-frame kind of fixation. You have to bend the rod and make it take an angle at the joint, because what do? Do you leave the patient? Do you leave them for amputation? So I have seen a lot of improvisations when we know the best would be this, but let us do this. So that story of poor care for poor people is apartheid in its own self, is segregation and racism in its own self, and the only person then who owes the poor citizen their care is only the republic or themselves. I think that is where it gets extremely painful for me as a surgeon, as a healthcare provider. I talk to the family, I tell them this would be the ideal. They say, I cannot afford it. Now it's upon them or the state, because the state is supposed to be able to cater for the poor people in the society. They have the social contract theory with the population. They have the social contract with the population. We are going to help you in this and this. Now, that is where the crux is, because there are few who can afford where infrastructure is, but those who can't afford where infrastructure is, how does the government reach them and make sure that they don't just get poor care for poor people, but they get quality care, even if they cannot afford it, because they have a mechanism of protection. So if I have to cap that again, we've said you will end up with poor outcome, postoperative mortality or perioperative mortality. You will end up with delayed intervention and harmful delays, both for elective and for emergency cases. And you will end up with a lot of improvisation. And that improvisation sometimes is fodder for the funding colleagues, because you will hear a lot of task shifting and task sharing, and you will hear conferences where someone wants to say, oh, the clinical officer actually did a Syrian section even better than the gynecologist. And I just walk out of that conference hall, because what kind of conversation is that if we have colleagues who come from countries where cesarean deliveries are done by gynecologists, and they come here and tell us, you don't even need a doctor, you just need a clinical officer, train them how to do it, and they will do it like a gynecologist. So that perspective is completely wrong. Task shifting is one of the way to sanitize the ills that we have because we can't afford. Back to you, Irene.
Dr. Ria, you bring very important points to our discussion. The discussion about task shifting can be a whole session for next time. But talking about quality of care, talking about improvising and all that, I want us to move a bit into surgical policy making. For a few of the African countries, they have been able to develop their national surgical anesthesia and obstetric plans, which is the NSOP. For some of the countries, these NSOPs have been developed and left on the shelves because strategies to implement the policy was not considered during the development of the policies. Whether we like it or not, public health or health policy is politics. How do you see our political atmosphere and surgery? We have a lot of people talking about TB, HIV, malaria. We have the Global Fund focusing on TB, HIV, malaria. do you think Africa is ready for policy in terms of surgical systems? What is your take on NSOP development and its implementation across Africa, Dr. Aja?
Oh, thank you for that question. I don't think so. One of the arguments is the surgeons should be politicians as well. So I'll give you what has happened in Nigeria. We had Professor Adewale, he was a gynecological surgeon. He was Minister of Health for, I think, 8 years. And then I think the current minister is an orthopedic surgeon. So I don't think that's the case. I just think the funding must come, majority of it must come from internally. And sometimes when I speak to the Nigerian media, they don't like to, they have a problem with this kind of conversation. But the truth is, if the patients will get, think of anywhere where patients get their surgeries on time. The funding for that surgery comes internally. Now, it's a debate whether you want the patients themselves to pay or you want the state to pay, like Dr. Stanley has argued. In the UK, the state pays most of it. In the US, the patient themselves pay most of it, but it has to come internally. If we take some money from UK defeat and they give us three years funding, and we're doing all of these good surgeries, when they no longer have that money, because money is, the UK's economy now is shaky. You know, we've got, I think this is the fastest non-scandal sacking, or not sacking, resignation of a world leader. So countries themselves that can donate also run into their problems. And if you look at even Canada, their model, when the countries become less rich. So that needs to be paid attention to. Now, it's much more like a politician that is interested. If the politician is a surgeon, probably makes the work easier. But the evidence from Nigeria has not shown, in my opinion, respectfully, that we've had surgeons at the highest level of Nigerian healthcare. And I don't think the patients are getting more surgery. We can look at, analyze the data during their tenure. Professor Adewale was, in fact, 3 times. There was the orthopedic surgeon, Onyebuchi, that was during Jonathan, then Professor Adewale, and then current 3 times. So I think 16 years. We can look at the data and even compare with the non-surgeons. In terms of the national policy, I agree with you. The colleges maybe can do more. The professional bodies of surgeons can do more, sort of looking at what we need. We have to also give the college credit, because if you look at COSEXA and WACS and CROSS, they've actually designed the curriculum to fit the need as much as possible, so that we get surgeons early. Because WACS have said, we're looking for surgeons that can go to market as early as possible. We're not looking for someone that must necessarily know how to do transsphenoidal pituitary surgeries, because in most of Africa, how many times do you do that? We're looking for someone that can do a borehole, evacuate a hematoma. And oftentimes in some of the African countries, 4 years of continuous surgical training is enough. And the idea that if some things should be tax shifted, I think we've passed the era of that. We have in most of Africa enough medical schools to produce doctors fast enough. We have enough colleges to produce. I mean, if I'm in Cameroon, I can go and train with WACS. I can go and train in COSEXA. It's recognized. I can go and do an MD. So there's how to train. So the thing is, the funding, governments in our countries must accept that the funding, majority of it, must come from within. And this is not what they like a lot, at least in Nigerian media. And then I talked to them one time and they didn't want to invite me on their on their platform again. But it has to come from within. If 60-70% comes from within, and yes, we get some money from America, we get from Australia, what happens is the money, the investment from the other places become more useful to us, because when they come, we fine tune those. And when they say, oh, we no longer have the money to give, or they change their mind, it doesn't become a big shock. Yes, but until that comes, The national soaps are not very difficult to write. We know the surgical diseases that our people have. We know the commonest ones. We know what needs to be done. We know what is needed in the theater. We know what is needed in the community. The colleges know how fast to train these people. And so it's not complex. We know what our nurses need. We know what the anesthetists need. And but the funny thing is the population are not getting it. So once that money is coming from within, if the politicians accept that they would do everything within, it doesn't need to be perfect to make that happen. And then I think more procedures will be done, you know, not as fast as most developing countries, but certainly we would move from where we are to. But in terms of whether we can train surgeons in Africa, there's no doubt. I think if you even compare, you disaggregate the data, we have a really institutions where we are ahead of some of the countries in Europe and all of that. And then the knowledge that a surgeon trained from Africa, I mean, the facts are there. All surgeons from, whether you go to US, you go to Europe, here in the UK, the facts speaks for themselves, so that we have the knowledge to do the job, that whether you are from Africa, you're a surgeon, you can operate on anybody regardless of race, and the outcome will be excellent. The facts are there to speak for themselves. But of course, the environment needs to be as conducive. That's just the defining factor. I think I've spoken too long. I'll go back to you now.
Thanks very much. I think we have Dr. Mokake Martin with us now. You are welcome, Doctor.
Thank you very much. I appreciate.
We learned you were having some network challenges. We are glad you have been able to join. So we have been talking about the surgical situation in Africa. We've been speaking about the hindrances to the development of surgical care in Africa. We've spoken about infrastructure and human resource and how that has become a hindrance to improving surgical care in Africa. So once you've joined us, we'll continue from there. But there is this dicey question that I want to ask Dr. Mokake, if you can address for us. We have heard news that for most of the people who are a bit wealthy in Africa, and sometimes even our politicians, when they need to access surgical care, they travel outside of sub-region to seek surgical care in high resource settings. People have argued that they should have focused on putting in place the infrastructure and, I mean, the resources we need to provide that kind of care. What do you think is the main reason why we have people who can afford traveling outside of our sub-region to access care? And do you think if everything is put in place here, they would like to stay and access care here? Or there is a special reason why they access care in high resource settings?
Thank you for that question. I think that it's, I look at it from different angles. Now, it's a shame, but we should underscore the fact that we do not have confidence in what we have. And that is the first problem. We do not trust our systems. And those same systems that we attribute a lot of mistrust to are created by us. And so we find a situation whereby the wealthy, those in power, have failed to put a reliable structure on the ground, and hence they lack confidence in the work that they have done. And hence they need to go somewhere else to get the same facilities that I believe that we could have had in our own area. So that leads me to the fact that even if we have those structures put in our African context, and we have those structures, the wonderful platform to work with, the human resources, the infrastructure, I still think that some of these people will still go out for the beginning of some time. They would still take some time going out, because it would take a lot of time for those people to regain trust in the system whereby they have been able to destroy. So I think that, yes, putting the infrastructure on the ground, it's going to make us stay in here and do the things by Africans, for Africans, and for any other person who is interested. But yet we find a situation whereby we need to first of all do what we have to do by bringing this infrastructure, training as much as we can train, changing our own mentality, and then we would see that the little few that would lag behind would join us when we tell them that we have confidence in our own system that they have so much destroyed.
Thank you very much for your point. Is a lack of trust in the system we have. Sometimes you forget that the same system we are creating is the system we'll still run back to access care. So wherever we find ourselves, we should all try as much as possible to improve the system in our own small ways. I'm sure that we are almost getting towards the end of our discussion, and I'll go back to Dr. Stanley Aruyaru. Based on all the issues we have discussed today, now I'm out with my pen and write down what key things do you think we can do to improve surgical care in Africa?
Thank you, Irene. Great question. And I totally resonate with Martin's response just a while back. Like Jonathan said, we know what needs to be done. If you go to any ministry, they have policies that are gathering dust on the shelves of the ministry. If we look at the Nigerian case and even the Kenyan case, by the way, we once prayed until we eventually had a doctor as the Minister for Health and a doctor as the Permanent Secretary for Ministry of Health. And during that tenure, we had the worst corruption scandal in the ministry. So I think we can still argue and eventually comes back to integrity, not necessarily the title of the doctor or the specialization, but the integrity of the person holding the office. Now, for me, it will be implementation. If we just decided every ministry to go back to their shelves and their cupboard and see the policy or the strategy that is there. In Kenya, we called it ENSOTA. It was supposed to be launched. I was part of the group that was making it. It was supposed to be launched during the Surgical Society conference. The minister got another appointment. That was the end of it. We've never heard about it. If the respective ministers go back to the shelves, they will find crafted policies that have the solutions to all the problems. If they do not want to do that, the one single thing I can say is a silver bullet to fix the surgical healthcare problem is to fund it. Where you put your money, you put your mind. Where you put your money, you get serious because you don't want to make a loss. So if they actually want to see difference, let them pump money and come back and ask, where did our money go? This is when people will get serious. Otherwise, talking and drafting policies has been going on since time immemorial, and it doesn't help unless they're implemented. So let's go back to the shelf and let us put our money where our mouths are. Thank you, Irene.
Dr. Aruyaru says, let's put our money where our mouths are. That's a very important point. Dr. Aja, based on your experiences across the world and your experiences in high resource settings, what do you think we can do here in Africa to improve our surgical systems?
I would say that we need to do it now. It's an emergency you need to do hernia surgery, which you do like AM, PM lists. You could do 14 in the UK in a small hospital. And so it can be done, just like Dr. Stanley has said, implement it. It's an emergency and the politicians need to accept it. Yes, if the politicians accept it, they have every mechanism to give us the funds we need. They say they don't believe us. Who do you think does their surgeries when they come to the UK? I can tell he's not a white doctor because I know if they go to the US, it's not. Because majority of the surgeries that is done in England, it's not, it's done by everybody. Nobody checks once surgeon is certified. So our people that come to these countries get operated by our own people, but they trust now because they know that the system, you can look at the Nigerian scandal, for the deputy president. He thinks, okay, my daughter is good enough to get transplant. We have more than 100 surgeons that can do a kidney transplant. What does it take? You take the graft, you anastomose the vessels, you put it in the pelvis. What's special about that? But the post-op care, like Dr. Stanley has said, is going to be problematic. So they take it as an emergency. The politicians know what the funding. Do you know the interesting thing? Our senators, they always get paid in dollars. Their newspaper allowance doesn't go missing. Everything they need, their ESTA code. So if they start doing it as an emergency, I'm very sure in the next 5 to 10 years, it's when they go out overseas, it's the same Africans like them that do their surgeries. So what's the difference? Maybe it's the plane.
The plane. Perhaps it's the flying in the air. Thanks, Dr. Aja. Dr. Aja says that surgical care is an emergency now, and our politicians need to accept this. Dr. Mokake Martin, so what do you think we can do in Africa to improve surgical care? You're muted, Doctor.
Thank you for that question. I feel that we can be able to begin by encouraging the national health insurance policy for African countries, because paying for surgery out of pocket is a nightmare. It's like we are selling enchanted waters. We never get to a destination. And it goes back to what my wonderful colleagues have said, government policy. Because if every country, this is a principle where Northern Africa has been able to go far into it, and so we see their problems are lesser than those of us in the sub-Saharan Africa. If every African can have access to quality care through a national insurance policy, I think surgery in Africa would move from one level to another in a very short period of time. Thank you.
Thank you very much. I see Dr. Valerie Ngo on the call. I know he's also an expertise in global surgery and public health. Dr. Ngo, do you have any comments on the discussion so far? So while we wait for Dr. Valerie Ngo to comment, the floor is also open for 2 or 3 questions. If any of the audience wants to have a question, you can just unmute yourself and ask your question. Otherwise, you can type in the chat or in the Q&A session. While we wait for a few questions, we want to say that this discussion has been very fruitful. We really need to look at the surgical situation in Africa here as an emergency. For me, I see it this way, that for whichever part of Africa we find ourselves, you don't know the next moment where you will just trip and fall or break a femur. I mean, there are a lot of road traffic accidents going on. Every minute, a child is born with a congenital anomaly, and it is very closer to us than we think it is. So, I mean, it's not everyone who can travel to access healthcare. And most of the things we are talking about are affecting immediate family members of us. And so it really needs to be treated as an emergency. Dr. Aria also mentioned from the beginning that we should all become advocates for global surgery. I think grassroots advocacy is very key. One of the reasons why HIV advocacy chalked the success it chalked was because patients put themselves together and advocated for what they thought was right for them to access. And so advocacy is also very important. Well, if we don't have any more questions or we don't have any comments, and while I wait for Vanessa to take over, I'll conclude that this discussion has been fruitful, and the take-home messages were that we should put our money where our mouth is, and so we should rise up, and it's about time we invest in the surgical situations in our country. Dr. Aja also mentioned that surgical care is an emergency, and our politicians should accept it that way and begin to invest in it. Dr. Mokake also closed by saying that we should work on our national health insurance schemes. Of course, for the countries in Africa who have introduced a form of national health insurance schemes, Though it has eliminated catastrophic health expenditure to some extent, it has not totally eliminated out-of-pocket spending. Patients are still paying for laboratory services, for scan and all that. And so Dr. Mokake also mentioned that we should focus on the National Health Insurance Scheme. On behalf of the Nkafu Policy Institute as the Dennis Elinora Foundation, I wish to thank you all panelists. This has been an interesting conversation, and we would love to have you a lot more times to discuss this particular issue about surgical situation in Africa. Thank you very much for your time.